Thanks, Susan. So it's a real pleasure to introduce today's speaker, Dr. Abhinav Sharma. Dr. Sharma is a cardiologist and assistant professor in the Division of Cardiology at McGill University. He completed med school and internal medicine residency at McMaster and a cardiology fellowship in Alberta, followed by a PhD in epidemiology with a thesis focusing on the intersection of diabetes and the heart. He went to Duke University to complete a cardiovascular research fellowship, then went on to Stanford University to complete an advanced heart failure and cardiac transplantation fellowship. He's a Junior 1 research scholar supported by FRQS and also holds research funded by CIHR. His research focuses on optimizing therapies in people with diabetes and cardiovascular disease. So please welcome Dr. Sharma, and I'll pass it over to you, Abhinav.
Thank you so much for that very kind introduction, and it's a great pleasure to talk to everyone here. Hopefully at some point we can restart this in person as well. So a lot of my work and research work focuses on the intersection of cardiovascular disease and diabetes, but a big sort of third triangulation focuses on leveraging digital health technologies. So today I'll be talking about the development of digital health applications for cardiovascular research. But by applications, I'm going to sort of broadly talk about digital technologies. Here are some of my disclosures. And really, I'm going to sort of introduce digital health in the context of clinical research and highlight 4 different technologies that I have sort of worked with in the past, highlight some of the pitfalls, some of the lessons learned and mistakes that I've made along the way. And hopefully we can open it up to a robust discussion around challenges and opportunities. I'm just going to be setting a timer for myself because I have a tendency to keep on going. So just to make sure that I'm on track here. So digital health research and the integration of digital health in clinical research. So the healthcare industry until very recently has largely been excluded from the advances in digital health, but it's currently the availability of powerful and low-cost computing plus funding from the government and industries that have resulted in major advances in the use of digital technologies. This has really helped to facilitate both healthcare deliveries and optimize clinical trials. However, this is still in very, very early phases. And so we could see from this article in The Economist that the cost of data on the right side of your screen has dropped substantially over the years, and the mobile broadband connection availability has increased over time. And looking at the slide on the left, looking at mobile penetration, you can see that the vast majority of people here in 2023 do have some sort of mobile phone with data plans, and the proportion is increasing in Asia and Africa and the Middle East as well. So when we looked at sort of the use of digital health technologies within clinical trials, this is a couple of years older at this point in time. It's an analysis that we had done. And when we see even just a decade ago, a really small number of studies looking at mobile devices or wearables and sensors, and it's exponentially increased over time. And now when we have looked at repeated updates on this, the numbers are even higher in terms of the studies that are using digital health technologies within clinical trials. So several emerging technologies have come up that I believe will actually help to really disrupt the clinical trial infrastructure and healthcare delivery infrastructure. And the first is mobile phones and mobile applications. And in addition to this, the associated wearable devices that can connect to mobile devices. The second that I feel is a really emerging technology is the use of voice-based technologies as well. You may have heard of this from the context of Amazon Alexa, Siri, Google Home, but I believe that this will be playing a bigger and bigger role in healthcare delivery and clinical trials. So as I mentioned, there were 4 big topics that I wanted to cover today. So the first topic that I wanted to look at was geolocation technologies to enhance the use of clinical trials. And where this idea came from was the fact that we use digital technologies and mobile applications in our everyday life, right? So geolocation can really change the way we think about trial data. So when we take a look at our mobile phones, a lot of us here have used Uber in the past, we've used Google Maps in the past, we voluntarily agree to basically be tracked by these applications. And if I say, hey, I need a car at Côte-Neige, you press the button and there it is. Or I need directions from point A to point B, there it is. what if we can leverage this geolocation technology in a similar way to clinical, leverage the geolocation technology similarly to what we do in our day-to-day lives, but use it in clinical trials. So when I was at the Duke Clinical Research Institute, we had developed something called the Capture platform in collaboration with the Duke Clinical Research Institute. So what was the philosophy behind this? Well, let's say if you were part of a clinical trial, you would download the Capture platform onto your mobile phone. Subsequently, you would be geolocated. However, there would be a blanking so that we cannot identify your location. And I think that's very key. You could not identify an individual's location. However, there were specific locations in which we had geotagged within a map to indicate that if your GPS overlapped with a geotag location, a notification would be sent to the clinical trial team. So for example, if a patient was hospitalized and we had geotagged that hospitalization, and if a patient brought their phone along with them, that would send a message automatically and would alert the research team that a patient had been hospitalized. Why is this a big issue? Well, we know that identification of hospitalization events is absolutely critical in clinical trials. And we know that relying on patient-reported, self-reported hospitalization is extremely poor. So we need a really motivated and strong way of actually using geolocations in the context of clinical trials. So this is the platform in action. We call it the D3 application. This is just the wireframes going from the left to the right. You'd be onboarded in terms of the application. You would download the application and you would allow us to access your location. All of this was, of course, consented. And then let's say you go on your merry way, but you showed up in the hospital. Are you in Duke University? A pop-up would come up and say, based on our data, it looks like you're in a hospital zone. Is that correct? You can say yes or no. And if you click yes, a short survey would come up saying, hey, like, what's going on? Are you hospitalized? Are you visiting? Is there something else happening? And even if a person didn't respond, the fact that they're in a hospital environment gets tagged. And so a clinical research nurse can follow up with the patient to say, hey, were you actually hospitalized? Were you actually sick and unwell? So this really shortens the time from hospitalization to identification of a clinical event. And so when we tested this in a small pilot looking at hospitalizations in people who've had the mobile application, we did this in 3 countries around the world, and we identified that the sensitivities and specificities for identifying hospitalization or identifying when the phone was in a geotagged hospital location was close to 100%, meaning that the phone was very accurate in saying, hey, a person is in a hospital, and very accurate in saying, no, the person was not in a hospital. This could really change the way we think about how do we identify people in clinical trials. Now, I talked about some of the other technologies that I think that may have a lot of advantage, and this is voice-based technology. So I'm going to talk a little bit about some of our voice-based studies as well. And by the way, I'm going through some of these examples pretty quickly because I want to really open it up, and I think the discussions where a lot of the fun points are going to come up here. But so let's talk about voice. You may have all heard of the Amazon Alexa. It's a device. It's a home-based assistant. You can speak to it. You could say, hey, Alexa, turn on the lights, add something to my calendar, set a reminder, what music is playing, what bands are playing around me. It's meant as a tool to really facilitate your day-to-day life. The use of these devices has exponentiated over time, with now estimates ranging that approximately 1 in 10 to 1 in 20 people already have this type of device within their home. So the question that I thought of, and we did the study when I was at Stanford, was how can we use this voice-based technology that you can interact with to order food, to order medications? Can we use this in a way to actually capture clinical trial quality data? So we ran a small pilot and we looked at the score called the Kansas City Cardiomyopathy Questionnaire, KCCQ. In the heart failure world and in the cardiology world, the KCCQ is a very validated questionnaire that enables us to identify a quality of life. And this has been approved by the FDA to accurately measure quality of life in individuals. So you can see some examples of the questions here. So heart failure affects people in different ways. Some feel shortness of breath while others feel fatigued. Please indicate how much you're limited by heart failure. So, showering and bathing, limited, extremely limited, quite limited, moderately limited, slightly limited, not at all, limited for other reasons, or did not do these activities. So depending on how you score, the higher the score, the better you are, the lower the score, the worse. So we converted this into a voice-based system. So you could just talk to this Amazon Alexa and determine if, hey, are individuals actually capturing, or can the Alexa capture this data in a way that would mimic what would happen in a clinical trial? So we gave 35 people pre-filled KCCQ questionnaires and said, hey, look, if you were to ask the Amazon Alexa, or if the Amazon Alexa were to ask you these questions, what would be the correlation? And if you responded, how would this correlate? And what we found was that compared to a paper version of the KCCQ and the Alexa KCCQ, there was a concordance, a Kappa concordance score of 0.94%. Now, it's not perfect. You could see in some individuals, there was a bit of a discrepancy within the scores. Some individuals had a tough time understanding the Alexa. When individuals responded to the Alexa, sometimes the Alexa didn't pick it up. So it's not perfect, but it's pretty good overall. And this was the Alt-Blattman plot when we looked at, how many people had a deviation in the score. So we usually consider a 5% change in the KCCQ to be clinically meaningful. And so overall, a very small proportion had a score that sort of deviated from 5% from the gold standard, which was the paper. So this really highlighted that voice-based technologies can be used to collect clinical trial grade data. Now, COVID happened and we tried to, sorry, I'm getting spammed here. So COVID-19 happened and we thought, can these technologies be pivoted? Can we convert this Amazon Alexa from a heart failure to actually help with the COVID pandemic? Oh my gosh, sorry, 1 second here. Just gonna turn that off, okay. So what exactly did we do? Well, when I remember in the first and second waves of the pandemic, we had people coming in and out of the hospital. They were being screened by a human individual saying, hey, do you have a cough? Do you have a fever? Have you traveled? Have you been in contact with someone? I thought that this was extremely inefficient, right? Could we replace this tool with a voice-based tool that could do this task more efficiently? And potentially could this then be used in different areas? So we ran the Voice COVID study, which was sponsored by MI4, or Voice COVID 2, which was sponsored by MI4. So what we did was we took the Amazon Alexa, we created a mobile application with the Amazon Alexa and placed this in front of our cardiovascular clinic. As you may know, at the Glen site, it's on the RC level near the Queen Victoria statue. So as people were coming in, we had ethics approval to verbally ask if they would want to be screened by the Amazon Alexa. So we had an N equals to 215 participants. The median age was 46 years. 55% were female, 45% were male, 69% spoke English, 31% spoke French, and we had the application, the voice-based application in both French and English. What we wanted to see was that if a person got screened by a human and then got screened by the Alexa, what was the concordance? Could an Alexa do just as well as a human? So first step, the individual was screened by the healthcare provider. And the second step, they were screened then by the Amazon Alexa. It was a two-step process. The screening questions included asking questions around international travel in the past 14 days. Had they been in close contact with a person with COVID-19? Did the individuals have presence or symptoms, which included cough, fever, running nose, sore throat, or diarrhea? We were not analyzing their voice. We were not seeing, oh, does their voice signature look like they have COVID or not? That's not what we were doing. This is more looking at the screening process. And so overall, we had 645 screening questions were delivered. The Alexa misidentified only one response. And so the primary outcome, which was a Kappa and COA, Cohen's Kappa inter-rater reliability, demonstrated a Kappa of 0.989, so very, very, very accurate. The median time from completing the Alexa from starting to finish was 40 seconds, so maybe a little bit longer than what a human being would do. But in terms of our feedback, we had a post-survey question out of 5. 4.5% out of 5 was the median feedback for ease of understanding. 4.7 out of 5 was ease of understanding. 4.5 was ease of use. 4.4 was overall rating. We got overall pretty good feedback for something that we very rapidly implemented and put together. Then we subsequently took some people who wanted to have a post-survey questionnaire and post-survey screening questions. So if you could look at the right of the screen here, so within the Voice COVID-19 study, we took 215 participants, and of them, 27% of them filled the longer post-screening survey. And just to ask them questions about, well, what was your interaction like? Was it really awkward? Was it enjoyable? Did you have a good time? Was it terrible? Overall, we found that 22% of individuals, we found almost 5 major themes. So 22% sort of focused around this idea of universality. So people liked it, but would I be able to use it in other locations? 7% had concerns about therapeutic alliance. They didn't feel comfortable with the device. 34% had concerns or questions around interaction, meaning they didn't understand certain things the Alexa was doing specifically. And then the communication, so the actual pronunciation of the words that Alexa was saying, 37% of individuals had questions around communication. And so overall, the use of these sort of artificial intelligence-based voice response system, which is our fancy term of the Alexa, showed that this was actually very, very cost-effective and could possibly be implemented in a healthcare environment. But there were these still major themes that had to be addressed. Okay, so I'm going to jump right to the next thing that we were working on was physical activity. So with regards to physical activity, what is the problem we are trying to solve? So, based on this Healthy Future study, which is a pan-Canadian study, I want to highlight your attention to the yellow. We see that, more individuals are eating fruits and vegetables over time. So this is the x-axis is years, the y-axis is prevalence. So, 70% of people are eating more than 5 servings of fruits and vegetables per day. The proportion of people that are smoking is declining over time. Yet physical activity remains very modest in terms of targeting 150 minutes of physical activity per week, very modest, only around 42 to 45%. So there's a big gap in improving physical activity. And so, also while I was Duke, and this research expanded until while I was here, and that we just completed this study last year, we tried to say, okay, physical activity is important, but what strategies can we use to motivate and nudge individuals who are very, very high risk? So for example, those with diabetes and heart failure, and the combination of people with diabetes and heart failure. So we ran the Target HFDM trial. So this was the mobile health intervention to increase physical activity in patients with heart failure and diabetes. So this was our trial. Our background and objectives were that we know that regular physical activity is essential to optimize cardiovascular health. This improves outcome and quality of life in people with heart failure, improves glycemic control in people with diabetes. However, we know that the impact of behavioral recommendations is limited by poor long-term adherence. Mobile health interventions can provide a novel platform to improve health behaviors, but have not been rigorously tested. So the Target HFDM trial was designed to test the efficacy of a mobile health intervention in patients with both heart failure and diabetes on physical activity and medication adherence. So really the focus was on the physical activity. So what was the design? The Target HFDM was a pragmatic, multi-center randomized controlled trial at 6 clinical sites. I published this in our methods journal here in 2018. Excuse me, we had very broad entry criteria. Individuals have to have symptomatic heart failure, regardless of EF, and diabetes. They were not participating in a formal supervised exercise program, no significant cardiac impairments of physical activity, and they needed to have a smartphone. So individuals were randomized 1-to-1 to receiving a Withings Go. So Withings Go is a wearable device that sort of can track your physical activity. The data was abstracted from the Withings device and gone onto a cloud. This was then transferred to the intervention group as various nudges. And so, for example, here we said, oh, great work. You've improved your average step count by 250 steps. Let's try to increase to 4,000 steps per day next week. So all individuals, okay, but all individuals received this type of device, okay? However, it was only the mobile health group that received the feedback and incremental personal activity goals. So we based it on the prior week's activity. So we saw if an individual had done 2,000 steps per day, they would be nudged up to 2,100 steps per day. And so incrementally increasing their activity over time. And this was done via text 3 times a week. Now, there were 3 months of active intervention. Okay, so we did the intervention for 3 months, and this was followed by then 3 months of additional clinical data where we stopped the nudging. What we wanted to do was see how sticky the intervention was. So if we get people to move, can we then get them to continue after time? Okay, so our primary endpoint was the mean change in daily step counts from baseline to 3 months. Our secondary endpoints included changes in the KCCQ, so heart failure related quality of life, sorry for the acronym, but this was the KCCQ that I talked about before, from baseline to 3 months. Change in NT-proBNP, so this is a marker of heart failure congestion. Changes in hemoglobin A1C from baseline to 3 months. And some of the exploratory endpoints we looked at was change in median step counts from baseline to 6 months. And we also did some metabolomic profiling, which I'm not going to get into. But what this shows is how sticky is the intervention, even if it was stopped, do people just give up essentially? Okay, so in terms of our statistical models, we use changes over time to assess using generalized linear regression models adjusted for baseline measures. To account for missing or non-physiologic data, the primary analysis was limited to patients who had non-missing data at baseline and 3 months. Data was considered non-missing, okay, if at least 2 days of data were available and if it was within a physiologic range. So if people had between 200 and 20,000 steps. Now, some people very well could have had more than 20,000 steps a day, but if you have heart failure and diabetes, very unlikely. So in terms of a baseline demographic, we randomized 187 people. We were going to go up to 200, but COVID-19 stopped it. We had a distribution across America, several sites on the East Coast. We had representation from UT Southwestern and at Stanford. 35% were female, 47% were African American, 10% were Hispanic. The median age was 60 years. 66% had reduced ejection fraction. Almost all patients were symptomatic. All of them had diabetes as per inclusion criteria, and a lot of them had comorbidities such as atrial fibrillation. NT-proBNP was elevated, so this indicates that this is sort of an unwell patient population. Okay, so what was our primary outcome was the change in daily step count from baseline to 3 months, and overall between groups. So I'm going to point you to the red. The red is the median. So M health was the people who got the nudges. Okay, and the usual health was those who did not receive the nudges. As you can see, there's a baseline, a little bit of a baseline discrepancy in median step count. 3,600 had a step count at baseline. 3,055 was a median daily step count at baseline for the usual care arm, but this was not statistically significant. But remember, we were looking at the change over time. So it's not as critical what your baseline value is, but we're looking at the delta over time. And what we found was that we were overall able to increase your daily step count by up to 300 steps a day. That may not seem like a lot, but remember that with their baseline, that's a 10% increase in physical activity. That is actually huge. And when we looked at the usual care arm, there was actually a little bit of a decline in step counts over time. Okay, so our p-value was 0.04. There was a significant difference from baseline to 3 months. Now, when we looked at the extension out to 6 months, what we found was that it was indeed very sticky. So we were able to show that this intervention, people adhered to those motivational nudges over time versus in those individuals at month 3, this declined over time further. So really the mobile health intervention seemed to improve up till 3 months, and it continued thereafter. Okay, so also I'm going to walk you through, this is a busy slide here. So the first one was the mobile health. We see that the median step count delta was more than 300 between the two arms. The change in the KCCQ with the mobile health arm was quite significant. Remember, higher the KCCQ, the better the score. So we had a M health increased the median KCCQ by 6 points versus usual care only went up by 1 point. So this was a statistically significant change. There was no change overall in the markers of congestion or A1C within our particular study. The strength of our analysis was that this was a multi-centered multi-center study. We had high enrollments of underrepresented population. Majority of our individuals were African American. We had a high proportion of females, a high proportion of Hispanic individuals who were enrolled in our study. This is a pragmatic design using consumer technology. There was significant concordance between step count, quality of life, and metabolic signals, which I didn't quite get into just yet. But limitation was that it was, of course, a modest sample size. It was unblinded. And there was some missingness in step count data, but it was similar to other mHealth studies. And we only did go out to 3 months and then 6 months. I mean, this is not a multi-year study, but really shows that, you know, this has potential to improve physical activity over time. So in conclusion, in patients with both heart failure and diabetes, a 3-month mobile health intervention significantly improved daily physical activity as measured by step counts, mobile health related quality of life as measured by KCCQ. And I apologize, I didn't show the metabolomic profiles, but it actually significantly improved metabolomic profiles over time, but not A1C and not NT-proBNP. The treatment effect persisted beyond the active intervention period. And these data have important implications for more lifestyle measures in patients with heart failure and diabetes. Okay. So those are some of the programs and projects that I wanted to highlight, and I've sort of rolled through them very, very extensively right now because I want to sort of highlight some of our upcoming programs, and then I want to pause and really open it up to some discussion. So what is our upcoming program? So I've talked to you a little bit about the programs, that we've done with physical activity, with the voice COVID in the Alexa, with how we can optimize the identification of individuals who've experienced hospitalizations. But we collaborated with a group here in Montreal. So this was a company called Hop Technology. And so Hop Technology is a artificial intelligence driven mobile health platform. This is their team here. You may see some familiar faces. Kozar Khawaja, an ICU physician, is their chief medical officer. Dr. Tao Huynh is one of their, who is one of our cardiologists here at the Montreal General Hospital, is a collaborator and external advisor. Jean-Francois Sarrazin from UCPQ is one of their advisors as well. And they, of course, have a lot of advisors here, all the way from Mila to Pharma and others as well. And so, this is their watch and their device. You could see it's pretty small. It's not very heavy. And this, I'll talk to you about the sensors, but this basically tracks neurophysiologic signals within the individuals and projects it to their application. And then all of these individual components can be extracted. All the raw data can be extracted to do AI analytics on these individuals. So it's very, very exciting work that we are leveraging. What exactly are we measuring with this particular Hop device? So in the version 3, so in the version that you're seeing over here, we have a heart rate and heart rate variability. It measures skin temperature. Okay, so it measures motion and actigraphy and electrodermal activity. So electrodermal activity refers to the estimation of the conductance across your skin as measured by your sweat. And I'll talk to you about why that's important in a second. It also measures ambient conditions, right? You could see here that there's room temperature as well. And if you actually go in through it, there are sensors that can also measure the moisture content within the room. The version 4, which is coming up, looks at heart rate and heart rate variability, skin temperature, all of the other stuff, and it's going to add estimated blood pressure, respiratory rate, and blood oxygen SpO2. So this version will be coming out later in 2023. So, very interesting neurophysiologic signals that are coming about. And this company has been around for a while. They're not just a small startup company, but they've been around. They actually initially developed various algorithms to detect COVID-19 using both their application that you can talk into and through some of the parameters that they've detected on the watch. So as you can see here, if an individual is walking and moving, it will pull out an estimated VO2. It can create curves for body temperature, environmental information. You get the heart rate variability, actigraphy, R-to-R interval. The users can look at this and see this on the actual phone itself. And like I said, all the raw data goes up into the cloud. We've already signed our data agreements, and we have clearance from IT services who've already approved the use of the device. Now, what's very interesting about this is that once you have the raw signals, Okay, once you have the raw signals, that's actually when you could start to do the really cool AI deep learning analytics. Having a static measure of room temperature and skin temperature is great, but as you can see the curves over time and within an individual across the day, there's tons of deep learning that we can actually do upon these signals. And so, we're happy to announce that we were awarded a MedTech grant, and this is a collaboration to use this device excuse me, to improve the detection of people with type 2 diabetes. Excuse me. So what does this watch have anything to do with type 2 diabetes? Well, we know that individuals with type 2 diabetes have significant alterations in autonomic parameters, including body temperature, electrodermal activity. So we know that there can be temperature dysregulation. We know that individuals have abnormal sweat because of the autonomic dysfunction that they have. So their electrodermal activity may be different. They have significant differences in their heart rate variability. There may be differences in how they move as well. And so all of this data can be abstracted in a deep learning manner to help identify individuals who may or may not have diabetes. So you can imagine now a wearable device that could be scaled, or these sensors that could be scaled so that you can screen entire populations for people who are at high risk or low risk for having diabetes. Now, we don't see this as replacing the gold standard hemoglobin A1C, but think about the pandemic. Think about the number of people that may not have had the ability to see their family physician and get the routine screening needed. And also remember that patients with type 2 diabetes on average have 7 years. So they have 7 years of diabetes before it's detected. Okay, so this was demonstrated in retinopathy studies. And so really this is a huge area, and diabetes is such a public health disaster that we need to actually be better at identifying people who have type 2 diabetes. So we hope that this will be a sort of a really innovative way about thinking around how we can screen individuals. And so this is a collaboration between HOP Technology, MedTech, which is a part of the Ministry of Economy and Innovation. We have a pharma company, Boehringer Ingelheim, and the foundation have all contributed to help launch this important project. So what were some of the pitfalls, and what have I learned through transversing across these myriad of digital projects and different domains of digital projects? Well, for the one thing, it takes so much time to get up and going. We often think of mobile applications and devices that, oh, look, there's a phone, it's ready to go. There's a device, it's ready to go. Let's just go and start it. But it actually takes an immense amount of time, including interactions with REB, interactions with IT, interactions with data storage, interactions with the human component and the behavioral component of how individuals will respond and use these technologies. So what I've really learned is, and we saw this with the Amazon Alexa, there were some people who were talking into the device, who started to touch the device, they were getting frustrated, they were yelling at the device. We learned all sorts of things about what happens when you unleash these devices into the real world. And so one of the things that I learned is that take your time frame that you want to use and triple that, because it takes a long time to actually get these devices working, beta tested, pilot tested, and then implemented within clinical studies. The other thing is privacy. Okay, so this is a huge issue with IT, a huge issue with the REBs. Despite the fact that people regularly post intimate photos of themselves on Facebook and Twitter, and they give their location to Google and Uber, when it comes to research, the bar is very high to ensure that you maintain privacy. And so we came across this a lot with the geolocation technologies, and same thing with the voice-based technologies as well, as to how to create strategies to minimize disclosing sensitive information to researchers that we not normally would want to obtain. And so that is really device specific. That is really therapy specific, domain specific. And I'd love to have some discussions around some of the experiences that everyone here would have. The second thing is that it costs a lot of cash to get this up and going, and not only that, but a lot of cash to maintain. Okay, so it's not just building an application. You can go on to Upwork, which is a crowdsourced job finding repository, and you can get someone to build you an app for 50K. But if that application doesn't connect with your server, if that application doesn't give you the insights that you need, if it doesn't conform with regulatory requirements, it's not going to fly. And then to maintain over time is absolutely critical. Why is that? Well, because remember that mobile devices are not static. The phone changes, the versions of the phone changes, the applications have to change. People go in and out of Wi-Fi zones, non-Wi-Fi zones. As an example, when we were doing our voice COVID study, the Wi-Fi in the hospital often went out, and so our device just stopped working. So the cost to maintain this type of infrastructure remains fairly substantial. And then finally, the ability to actually clearly document what we're doing, the ability to clearly track what we're doing and display meaningful results is very challenging as well. What that means, for example, what we found with our target HFDM trial is that the step count data was hugely heterogeneous for some individuals. You had step counts going to 20,000, 10,000, 50, 100,000, so there's a lot of data processing, and you need a pipeline to clean and process the data. But once you had that built, I'm painting this all as gloom and doom, but once you've sorted out that workflow, once you've sorted out that baseline infrastructure, and if you have a little bit of funding to keep you maintained and going, then the ability to scale becomes really, really extensive. So you can then potentially, we could have screened thousands of patients with our Amazon Alexa, right? We could have enrolled thousands of patients into our studies on physical activity. And so the ability to scale and the impact is very, very broad compared to a one-on-one, one-person individualized randomized trial. And I can provide more examples later of how the scaling can generally occur. So this becomes a big challenge. And then the other issues we came across was, well, how do we self-sustain? How can we commercialize? This requires a really, really deep discussion with entities within our organizations to figure out how can we operationalize and commercialize these devices. We have now new leadership at the RI that's very supportive of trying to innovate and to try and move these things along. And so I'm very encouraged to meet a lot of the individuals that are here, that are trying to help us drive innovation forward. But that still takes a lot of time. The review process by the INP office, the discussions with the partnership office, the contracting. As an example, with our MedTech grant, it took almost a year to get the contract signed for MedTech, and we were right on the wire for being disqualified. And so it's not an easy process. I think we're all learning. Some institutions do it better than others because they've gone through it multiple times, but this is a big component, and that really needs institutional leadership, institutional infrastructure to value this type of work and to say that digital health technology is important, and we need to have people on the REBs, on the contracting, on the partnership offices to really be able to understand this type of technology. So where does this all lead to? Well, again, at the end of the day, I want you to if you can zero in on the orange, this is all about the relationship between the healthcare providers and the patients. We're not trying to break that relationship. We're trying to supplement and augment that relationship. And I would really encourage, if you're thinking about this, to really do a due diligence to understand how can this be sustained, who can be the industry partners, what are the regulatory components, and within your own institutions, is there resources that can be leveraged? Are there societies that we can approach? Are there developers within your core group that can provide advice as well? So with that, I know I've gone through a whirlwind of different studies. I'm going to pause, and I'd love to take some of your questions. So thank you very much. Ben.
Hi, Abhinav. Thanks for that really cool talk. I'm not an expert in the space by any means, but from your example and from what I've heard from other researchers here and elsewhere, it sounds like there's at least two applications of these types of devices. One is sort of biosensors for, I presume, prediction of things like heart failure exacerbations or whatever other type of exacerbations. And hopefully by predicting them early enough, you can intervene and improve outcomes. And the other application, if I can describe it this way, not being well versed in it, in the terminology, is like this interaction with like nudging or kind of getting in the patient's mind remotely to try to get them to adhere to things that might make their life better. And so I guess what I didn't see that you mentioned is that, and I have just watched the Theranos documentary, is there's probably this pressure from industry because there's a lot of hype, a lot of potential to raise funds, to make money, to make profit from the industry side. So what type of guardrails do you use to make sure that, you know, this is actually really meaningfully, I think achieving the goal that we want is, you know, improving the quality of life and the length of life, and not just hype. And the one anecdote that I have is like, when I first had whatever version of the iPhone that had the step count, like it felt like it was working. I would pay attention, and, you know, sometimes I would try to get over whatever threshold, but now I never look at it because I don't know why, I just lost interest. And so maybe that happens to all these like apps that get developed. I don't know. And so is there knowledge in that space about, even in the best of circumstances, do people actually continue to use things, or do they just tire of them and go back to whatever their usual routine is?
Yeah, that's a great point, Ben. And I think it really, like any answer, it really depends. I think, and I think this really ties into actually Kabiri's comments here. You know, the challenge is you're absolutely right. People's attentions are divided when they're on their phone. There's many other apps. You've got other things going on. Are they going to respond to the dings and nudges and the prompts and the pushes that will get them moving, get them going? I provided just some examples, but there are other really interesting examples that are being explored, such as, you know, encouraging individuals to adhere to medications, you know, getting people to make sure they attend their appointments. So I think it really depends on the field in which you are interacting. What we found was that the less interaction you need from the participant, the better it actually is, because people don't have the bandwidth to fully engage in their app all the time. Okay. Now, and it also depends on how high touch and how low touch you end up being. So as what Kabir is mentioning here, you know, is that if you have, and what we found was that our adherence rate in the target HFDM was very high because they were being followed by our heart failure clinic. So that enabled a therapeutic bridging and alliance between these two different groups. But the heart failure clinic was not necessarily, you know, nudging them all the time, but they knew that someone was sort of there in the background, kind of encouraging them. If you were to, let's say, release an app into the wild where there was no follow-up, we actually did this with the My Heart Count study. We had, you know, 60,000 people download the application, but then the use of it dropped to like, 60% of people stopped using it after a while. So you have this trade-off. You're absolutely right, between usability, high touch versus low touch, and the therapeutic domain. You know, Kabir, to go to your point as well, you know, we know that, you know, so our step count increase was a bit more modest, and these were sicker patients with heart failure. You know, so we don't anticipate their physical activity to increase as much over time. And you're right, you know, we didn't have multiple visits. There was only one touch point at the end of the study. So all of these things, Ben, tie into what you're talking about. And I don't know if I give a very satisfying answer, but I think it really depends on the intervention. And are you trying to sense which means that the patient may not have to do much, so the adherence may be higher? Or are you trying to nudge and cause behavior change where you may have much more variable rate of response?
Thanks. That's how clearly it's like a science unto itself. Maybe Nancy's going to comment on that. So as long as people are studying it.
Yeah.
Thanks very much for this. This is very interesting, and I certainly appreciated your comments both about medtech and about ethics. It took us more than a year to get our medtech signed. I almost gave up. It's really frustrating. I think the rules are very unclear, particularly if there's commercialization. And one of the questions I have for you, and you don't have to disclose this, but it seems to me that the research you've done, these are not your devices. You are not the person that's benefiting from the commercial aspect of it. Is that right?
Yes and no. Remember that commercialization can come out from various routes. You don't need to be the sole owner of a device in order to benefit commercially. All the algorithms, for example, for the voice COVID, we own. If we wanted to license that out to other groups who wanted to use it, we absolutely could. Now we're going to release it open source, so anyone can use it. But we could. Same thing for for the watch COVID. You're right. So for the HOP technology, we don't own the watch, but the licensing that comes out from the algorithms, if they license it to the Apples or the Fitbits of the world, the McGill will benefit from that. So there are different ways of probing commercialization for future IP and licensing.
Okay. Yeah, because what we're running into is that I have a McGill spinoff company. And of course, I am both the owner of the IP and the technology and the commercialization aspect and the scientist. And it's just a nightmare. And
I can imagine. That. And which is why I think the partnership with motivated groups, because for example, like with HOP Technology, they're very motivated in getting licensing agreements. So they have teams of people who are actually, that's all they do is like try to get these licensing agreements set up so that you as the scientist don't have to worry about it. Now that trades off with control. You lose control with that, and you have to be okay with that. If you want everything under your own umbrella, it's going to be very difficult.
So there's actually going to be discussion next week with ethics over how to manage these conflicts of interest, particularly for startups, where some of the funding is tied for that. Like we have AgeWell funding, we have HBHL funding, and it's tied to that. The investigator has to have something to commercialize. Otherwise, you're not eligible for the funding.
Yeah, absolutely. And so the conflict of interest arises where, Nancy?
Well, because I'm the PI on the project and I own the IP, and my company is at risk to benefit. So then we get other investigators. So but it's not a sustainable model for as we move forward, where we want to commercialize our own products rather than taking somebody else's iWatch and testing it. That's easier. That isn't a problem.
Yeah, exactly. So if you just want to do the testing and validation because it's good for science and good for research, that you can do. But you're right. How do we sort of protect our ideas, and how do we make sure that both the teams, the university, and the investigators benefit? And so these types of IP agreements and relationships become very interesting, and also very complex to deal with as well when you start to deal with larger and larger companies.
Well, I can invite you to that ethics meeting. It's gonna, if you're free, we're talking this next week, because a lot of projects have been just halted and the money will be returned. From those agents. But
maybe I don't understand. Is it being halted because the REB sees you because you own IP as having a conflict? Even if you were to give, let's say, another investigator
that's what we do. We have other investigators. We give other investigators the lead, or but it hasn't been worked out, and I think we're going to need a bank of investigators.
So what's the issue, Nancy? If you have another investigator, what's the REB's concern?
We'll find out on Monday what their concern is. So no, of course I have other investigators that aren't invested in the company, but the REB is still saying no, we're not going to accept that.
Okay, because that needs to be.
So I would have to withdraw as the PI.
Got it. Okay. Okay. Yeah, that certainly needs to be addressed, because then we're going to lose. We're going to lose to the Stanfords and the Dukes and the Torontos and the UBCs of the world if we don't, if we can't streamline this process. We will absolutely lose. And if McGill is seen as a place that's antagonistic,
it's antagonistic.
Then we will completely fail, and we will lose out on the innovation that's really coming from here. Absolutely.
Yeah. Anyway, that's so I'm a newbie into the entrepreneurial world, and that was like a really big block.
Right. So absolutely. So maybe let me go to the comments here. So Amy, are there any mHealth research frameworks that you could recommend that provide detailed, not just high level steps to consider? Amy, I tried looking for these. There are various frameworks. I would encourage you to look at the Digital Health Society or Digital Medicine Society. They've actually got 3 or 4 really nice sort of pitch deck documents that go through just for you to consider what to think about and how to think about it. The problem is that it's so domain specific. It's really hard to give general advice. It's really, really tough, Amy. So I think you really need to be domain specific, because of what's relevant in cardiology is completely opposite from women's health or OB-GYN or something. There's so much heterogeneity. It becomes very tough to give specific advice that way. But and so I'm going to Alicia's comments here. If you had to, how do you manage the chicken and the egg loop about presenting the grant with a technology partner and then complete the RFP process? That's meant to open up to all IT providers. RFP is necessary anytime there's a certain amount of public funds involved. Yeah, so this is it's a very tricky balance, right? So how do you balance the use of public funds that come in versus private funds? And so we have to have discussions with the RI groups before. There are ways of being creative around this, such as exploring with the foundation, if the funding can come through the foundation, or if you can get support there, because they're not considered public funding. And there's other sort of avenues in which you can explore, but it also depends then on the cost as well. So if you can keep it under, or phase it out. So you have phase 1 with a very specific deliverable that's under an RFP. So under the dollar cost for the RFP, you generate your results, you've got a completed project, and then you move to the second step and the third step. So it's not the full program, but you break it up into individual chunks. The second question was here: in the Watch project, in 6 months, the users got SMS, still engaged, but it was declining. Many made texting the users over a period of a year. That's a really good point. It's this thing of are people being bombarded too much, too little? We didn't test different strategies. So we only randomized people to once a week, 3 times a week, 5 days a week. We didn't see that. So it's hard to know, but we do still see that there's stickiness. After the 3 months, there was discontinued, and it goes to the 6 months, that there was a stickiness to it, that people still maintained some amount of physical activity compared to the control group. So then the other one, so Sharmila, who is one of our phenomenal nurse managers on my team here. You're interested in having patients exercise with a wearable. Could this help predict cardiovascular endurance? Absolutely. So there's lots of studies that are ongoing. And this is even some of the stuff that we could pull out through our innovation program on how to move forward. And certainly this could be a very interesting and novel way of using this data. I'm just making sure I haven't missed anyone with a hand up. Okay, so I don't see anyone else. So I don't know if I've made things more confusing or more discouraging or encouraging. Despite the fact of all these things, we were still able to launch these projects. We got the Voice COVID study going. We did get our Decide program approved by the REB, so that's going to be launching next month. So it takes time. It takes a lot of time, and so I'd be happy to discuss with people after the fact as well.
I think everyone really enjoyed your talk, and it was great to see both insights on your research, the results of your research, and the process, and also someone who's pursued it and gotten through it. So it's great to see that there is a positive outcomes. There are positive outcomes possible if you just have to be persistent. They're getting a lot of congratulations. So I think we'll end it there and wish everyone a good afternoon.
Great. Thank you very much for the invitation. Have a great day.